All right, good morning, everyone. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education Department. With me on this webinar today is my friend and colleague, Leanne Foster. Leanne is going to have some information that she's going to place in the chat for you as we kind of go through the presentation. And then she will be watching that chat for any questions or comments that you have as we go through this presentation. The first thing that we want to share with you is our disclaimer. We have prepared this document and the education we're going to provide to you as a tool to assist you in billing Medicare appropriately and getting appropriate payment. However, we do know that Medicare rules do change, and the CMS publications, laws, regulations, and rulings, those do take precedent over what we're going to provide for you today. We will respond to your questions, again, either through this presentation today or through a document following the presentation. But the Medicare rules do determine final coverage. And then CMS does prohibit recording of the presentation for profit-making purposes. So if you're doing screenshots or recording this, we would ask that you stop. We are recording this, and it will be available on the Encore page on our training center on our website, probably within the next week and a half, 2 weeks. It will also be available on our YouTube channel for you to take a look at. What we have for you here is just the CPT copyright notice. We are using some actual CPT codes and descriptions. Medicare does not own them. The American Medical Association does, and so therefore we provide this copyright notice. The next thing that we have up for you are some acronyms that we're going to be using throughout the presentation today. I like to gather them all up in one spot so that you have this as a reference should you need to figure out what one of these acronyms means. Medicare does tend to be an alphabet soup, so there's lots and lots of acronyms. So what we're going to talk about today are the Medicare rules for delivery services. That's the first thing we're going to talk about. And there are some special and different rules for delivery services from other surgical procedures. We're going to look at data to determine the most common services, we looked at data to determine the most common services provided by Specialty 16, which is an OB/GYN. We're going to discuss a couple of local coverage determinations and then also a psychological service. So let's start talking about delivery services first. Now, for Medicare, when you think of Medicare, you think of patients who are age 65 and over. They're probably not the ones who are going to be delivering babies. However, Medicare also can apply to patients under age 65 who are eligible based on a disability. And so these are the patients you're going to be providing delivery services to. So what we have up on your screen there for you are two procedure codes, one for a vaginal delivery and one for a cesarean delivery. Now, these two procedure codes that we have are the full delivery services, which would include both the antepartum, the delivery, and then the postpartum services. So what we provided for you here today is just some data that we gathered to determine how many services were actually billed for Medicare patients. And so we gathered this data as of 6/5 of 2024, and it is for dates of service March 1st through May 31st of 2024. So you can see here that we paid 139 services for a vaginal delivery. We denied 864. And when we get to the end of our presentation, we'll talk about some of the more common rejections and denials. And then we rejected 21. For a cesarean delivery, we paid 122. We had to deny 183. And again, we'll talk about why those are. We did not have any rejected claims for these two procedure codes. So let's talk about the global surgery indicator. This is part of the relative value file that CMS has available on their website. And for these procedure codes that go along with delivery, um, the indicator for that is an MMM. Now, most of the other surgical codes have either a 0, 10, or 90 day. And what that's talking about is the postoperative period. Well, for the delivery services, this works a little different. Um, This indicator, of course, there is the MMM, and this means that the E&M services prior to the delivery are considered part of that surgical reimbursement. So the information here on the slide shows you that CPT describes the antepartum services. An E&M to confirm the pregnancy is a separately payable service. So the patient comes into you today, they're saying, I think I'm pregnant. You're doing the confirmation of that and then determining what's going to happen going forward. That is a separately payable service. However, the antepartum services, and CPT describes these as monthly, bi-weekly, and then weekly services, are part of that global delivery service. And again, those are those two procedure codes I showed you on the previous page. The admission to the hospital is also included. So this could be the admission to an actual inpatient care, if that's what you need to have for the patient. If you're admitting the patient as an outpatient, that is also part of that global surgery. And then additional services can be payable when they're outside of what the CPT has described. So for an example, if you have a patient who runs into a problem, everything's going along fine, but now they have developed a urinary tract infection or a UTI, you're seeing them for that. That's outside the norm of what CPT is describing as those monthly, biweekly, and weekly services. What you'll need to have in your documentation, though, is why is that additional service medically necessary? And then you would just submit that into Medicare, and then Medicare can process payment for that. Another situation that you need to be aware of is that last bullet point there. Members of the same group with the same specialty, Medicare considers them to be the same person. So if you have Dr. Jones in your office who has been taking care of this patient and they've seen them for multiple evaluation and management, and now Dr. Smith is coming in because Dr. Jones is on vacation, they're part of the same group with the same specialty. So then you would bill to the delivery charge when you're doing that complete service. This also includes the global delivery service, also includes any postpartum services that are provided to that patient. The CPT does not give any numbers on how many postpartum services you need to provide. It just says that postpartum care is part of that global delivery service. One of the pre-submitted questions that we had, and I found this one interesting, not something I had really ever thought about before. What if you were doing delivery and it was twins or triplets or more than that? How do you do that? Well, if you're billing for the global service, and again, those two procedure codes we just showed you, then one of the deliveries, one of those babies, is the full antepartum delivery and postpartum charge. Any additional babies you can also bill, but it would be the delivery only services. If multiple babies do require additional services, documentation then would need to support that, and then that E&M service would be payable separately. So remember, when we're talking about this, Medicare's payment, and this is why this is important, Medicare's those antepartum delivery and post services, the pricing on that has already been determined to include all of the antepartum, the postpartum, and the delivery. So what that means then is you would not bill these monthly, biweekly, and weekly services separately. If your patient does run into a problem and it's outside of the norm, there's something else that you need to see that patient for, those E&M services are payable separately. You just have to make sure that your documentation will support that. And then we have services. We have the delivery only. This includes the admission to either hospital or outpatient, whatever the situation might be. If it's an inpatient, then you can bill the discharge management services, and I've given you the 2 procedure codes there. You can bill those separately from that delivery only procedure code. Any postpartum care, or there's also a procedure code for postpartum care only, and this includes any of the office or outpatient services you provide following the actual delivery. Teaching physician can situations obviously can be a great part of the delivery care itself. The teaching physician must be present. The delivery services are not part of what is considered the primary care exception. So that means that the teaching physician must be present during the E&M services, during the delivery only, etc. Now, for delivery only, that teaching physician must be present during the delivery. One of the pre-submitted questions that we had was that the baby came really quick, so only the resident was present. The teaching physician did get there prior to the placenta delivery, but the baby had already been delivered. Can the teaching physician submit the delivery charge? And the answer to that is no. What they would do instead is they would bill simply for the services that they provided. So let's talk about that for a second, what we mean here. So if you are doing delivery only, but you provided E&M services prior to, not part of a global delivery service, you can bill for those. Same thing with the postpartum care. If you're not using the 50,000 range procedure code to identify delivery only. If you are providing services outside of what CPT describes, you can bill for those separately also. When you're under the teaching physician guideline, again, teaching physician has to be present, and then you would append that modifier GC to the claim. That just tells us it's a teaching physician situation. So let's talk about the evaluation and management modifiers then. Modifier 24 identifies an unrelated E&M during the postoperative period. Now, for our maternity care services, specifically our global delivery care services, this is a modifier that you can use to identify those E&M services that are outside of the norm. That modifier 24 just lets us know it is unrelated to the normal process of delivery. You've got something else going on. Modifier 25 is used on the same day as a procedure. And for this one, your documentation has to show a significant, separately identifiable E&M service on the same day. So let's talk about that one for just a second when we're talking about delivery care. So the patient presents to the not the operating room, the emergency room, let's say for an example, and they're in hard labor. They're getting ready to have that baby right now. So the evaluation of that patient is part of that delivery charge. So that ER doctor then is delivering that child, and then the E&M is normally going to be part of that delivery. In order to be paid for that separately, the documentation has to show that the ER physician performed a great amount of additional work that could be identified separately from the work that goes along with delivering that baby. Modifier 57 can sometimes be used when we're talking about the delivery only procedure codes, and this is a decision for a major surgery. So let's think about how that could apply. Patient again presents to the physician's office, they present to the emergency room, and the patient is in some type of crisis. And therefore, that child has to be delivered today or tomorrow. So you're making that decision for that major surgery today, and that surgery is going to happen either today or tomorrow. This evaluation and management service, when you're billing the delivery only procedure codes, you can be paid for that separately, and that's when you would use that 57. The modifier FT is when you are providing critical care services following a surgery. So this could be several different examples that you could have. The patient, let's say they were in a car accident, and you're providing them with critical care services during the post-op period of the repair of the fractured leg or the repair of the spleen or whatever. And because of the pregnancy, because of what's going on with that patient, the patient meets the qualifications for critical care. Well, that's when you would use that FT modifier to indicate to Medicare that the services you're providing are not part of the recovery from that service. So let's take another example. The patient has a C-section, and then the patient experiences some type of problem following that. Their blood pressure spikes, they have a stroke. I mean, there could be all kinds of different things. And you're providing critical care services to them. In that situation, you're not going to bill for those because they're part of the surgical code that you had already provided. Now, you want to look at the procedure code you're choosing for your service specifically to see what the global days are that go along with that. So the next thing that we want to talk about is an LCD that we have, and this is pelvic floor dysfunction, anorectal. Uh, Now, wait, I got to get my head wrapped around that word, manometry and EMG. As I told you earlier, when we looked at doing this particular specialty, we did look at the procedure codes that were most common for them. So this is an LCD, a local coverage determination, commonly provided service by an OBGYN. This is a diagnostic test to assess muscle activities. We have the links for the LCD and the LCA within our resource section. If you look at this one, you'll notice that we have both an LCD, which is the local coverage determination, and then we have an LCA, which is a local coverage article. The local coverage article provides you with billing and coding guidelines. The LCD provides you with coverage guidelines. So whenever you're looking at an LCD, you want to look to see if there is an LCA, and then vice versa. If there's an LCA you're looking at, You want to look to see whether there's an LCD also. So for this one, the documentation has to support it. So if you got to look at that first bullet point there. The cause of the problem cannot be determined through an evaluation and an exam. So if your E&M service, you would need to document the fact that you can't determine the cause that would necessitate this particular procedure. The results of the test would have to be used in treatment of that patient, and that could be whether the tests are positive or negative. Your documentation needs to show how you used it. And then Medicare would not expect repeat testing, really no more than 2 per lifetime for the patient. So that's a conversation you'll need to have with the patient if you're considering doing this, to verify whether or not they've had this procedure done previously. And then the LCA contains the approved diagnosis codes. The next slide shows the most common denials for this procedure code, the 51874. The first one there is that the information that we had available does not support the medical necessity for the test. So this could mean that the diagnosis information was not submitted, or the information in the documentation, if we requested that, did not support the medical reason for performing this test on the patient. And then the second is that frequency limitation. This would be where the patient has received more than 2 in a lifetime. The next procedure code, or LCD, that we want to talk about is the cystourethropy with injections for chemodenervation of the bladder. So this is our Botox policy. And you can see we've got the LCD listed there, and we have the LCA listed there. Now, for both of these LCDs and LCAs, there's a lot of other reasons why a patient may be receiving the Botox injections. This procedure code, the 52287, is just part of, or one of those reasons that go along with that. So again, the LCD is going to contain your coverage information. LCA is going to contain your billing and coding. This would be the diagnosis codes and then also the procedure codes. You can see here on your slide that the results are expected to last at least 12 weeks. Medicare would not expect to see this more frequently. More than likely, if it's more frequent than that, Medicare is going to deny as opposed to develop on a claims level. And then you would need to submit an appeal providing us with documentation. And we'll talk more about the appeal process in just a little bit. And then also look at that last bullet point there. The documentation must show that the patient is benefiting from the injections. And that's going to be part of your documentation. How have the symptoms, how have the illness or injury, how have those gotten better since you have started on this particular treatment for the patient? We do have some additional information for you here on this procedure code. The drug that you're using is payable separately, but you do need to use the modifiers JW and JZ as appropriate, and we'll talk about that in just a second. It is 1 injection per site, so even if you're kind of using multiple pokes, I guess you could say, it is still 1 injection per site. And then the documentation does have to support what we've just talked about: medical necessity, dose and frequency, the effectiveness of the procedure, and then the site of the injection itself. Here are the most common denials for this procedure code. You can see here services are not covered by this provider. Now, there could be several reasons for that. You want to take a look at the LCD to see if we identify in there who actually can provide the service. You also want to make sure that you're checking your enrollment information for your provider to make sure that you have them enrolled correctly. We've talked about not medically necessary already. We've talked about exceeds frequency limitations. And then the last one, this is part of global surgery. So sometime within the previous 90 or 10 days, the patient has had another procedure provided by that same person or a member of the same group with the same specialty. So what you'll want to look at there is this part of that original procedure? And if it is, then obviously it's not billable to Medicare. If it's not, if it really is a separate service, then you'll want to look to the global surgery modifiers, which would be 58, 78, and 79, in order to determine which one would be more appropriate. 58 is going to be a staged or related procedure. 78 is a return trip to the operating room for a treatment of complication, and a 79 is not related to the original procedure. So let's talk in more detail now about modifiers JW and JZ. Well, the first thing that we need to determine is whether or not the drug is a single-use package. There are certain drugs that the way the manufacturer puts them together and the individual drug, all of that kind of stuff is only in a single-use package. You have other drugs for which you can use multiple times. So this only applies, modifiers JW and JZ only apply to a single-use package. You want to identify any drug wastage using that modifier JW. If you're providing the full single-use package as identified on the package insert, that's when you use the JZ modifier. So let's talk about some examples. First thing, again, look at the HCPCS description for the drug. For an example, let's say the single-use package is 10 milligrams. Well, the next thing you need to look at is the units of service as identified by the HCPCS code, the J code for the individual drug. So let's say in our example that the units of service is 1 milligram. So we know that in that single-use package, we have 10 units of service. If we provide the patient with 7 milligrams, then you would submit that with your procedure code, 7 units of service, and no modifier. The second line of service, you would submit, again, same procedure code, with the 3 milligrams, so 3 units of service, with that JW modifier. If you're giving all 10 milligrams to the patient, then you don't have any discarded, and that's when you use the JZ. Now let's talk about another example that kind of messes people up sometimes. Let's say that the HCPCS description for this drug is 1 unit of service is 10 milligrams. We have the same example. We're going to administer 7, and then we're not going to administer that additional 3. In this case, however, 1 unit of service is the whole 10 milligrams. Medicare does not take partial units of service for the drugs. So therefore, you'll just submit it on 1 line of service using that JZ modifier. The important part that you want to keep in mind here for these modifiers are, is it a single-use package? What is the units that are in that package? What does the description of the CPT code state is the actual units of service that you'll submit to Medicare. And then if you have drug wastage or you're discarding drugs, that's when you use the JW. If you're not discarding anything, that's when you use the JZ. The next procedure code that we have here for you is not really a surgical code, but we did want to bring this one into this presentation as opposed to into the E&M one we did last week, I think it was. So this procedure code, the 96127, is a brief emotional behavioral assessment with scoring and documentation per standardized instrument. Okay, well that provides you with a lot of information there. Okay, number one, you're going to be providing an assessment of this patient. Number two, it's going to be a document that is a peer-reviewed document. So whatever scoring or testing that you're doing, it's not something that you've kind of made up in your office. It is a peer-reviewed document. And then there has to be scoring on that. And then the documentation will be what is the patient's score? What am I going to do about that score? And then, what instrument did I use? We have two different LC or an LCD and an LCA that goes into this. Now, these are broader than just for OBGYNs. You want to, as part of this, you want to determine the functional consequences of known or suspected brain dysfunction for that particular patient. So you can see here it is a complete neurobehavioral status exam prior to the testing. So you want to be performing that prior to doing the testing that would be submitted using this procedure code. Test again has to be a peer reviewed. You have to have an examiner who knows what they're doing. So that examiner has to be clinically trained in order to do that. That's documentation you'll need to keep within your office records. Who is the examiner? What training have they had, etc. And then as part of your documentation, you'll have any diagnosis information and then what your treatment recommendations are. And then, of course, the scoring itself. And this includes the procedure code itself, includes the selection of the testing, the administration, and the scoring. Those are not billed separately. And then the most common denial for this service is not payable by this provider. So again, you want to make sure that the provider enrollment is correct. You want to look at that LCD and the LCA to determine who actually can provide this service. If it's being provided by someone, that Medicare says can't provide it, that also could result in this denial. The next thing that we want to talk about then are the National Correct Coding Initiative files. Pardon me for 1 second. There are two files that you want to be aware of. One is the procedure to procedure edits, and then one is the medically unlikely edits. The procedure to procedure are where CMS identifies what they call a column 1 procedure code, which is the payable code. The column 2 procedure codes are not payable. They are considered to be part of that column 1 procedure code. And then on the next slide, we'll talk about some of the exceptions to that. Medically unlikely edits have to do with the units of service on the same day. So for the procedure to procedure edits, number one, it's the same date of service, it's the same provider. And remember that specialty under the same group. And then of course it's on the same patient. Some of the different combinations can allow modifiers to allow for separate payment, but you really want to look at those modifiers. You could be having an RT or an LT modifier. There are fingers and toes modifiers, etc. There's also, however, modifier 59, and we'll talk about that one in a second. And then again, the payable code is in column A. So here are just some of the modifiers that you can use to tell us that this really is not the same service. Now, the 59 modifier is listed for you first. You only use that one if no other modifier can apply. You want to look at your X modifiers. You want to look at your right and left modifiers. The X modifiers is going to be a separate encounter for the XE, separate practitioner for the XP, separate structure for the XS, or the XU, unusual or non-overlapping. So what you're looking at here is it really is a distinct service. So let me give you an example that's not really specific to OBGYNs, but it's a fairly good example. You have the patient has a lesion on their right forearm. They also have a lesion on their right shoulder. So both of these, are on the right, so an RT or an LT is not going to help you here. Both of them are on the arm, but they are really on separate parts of the arm. Therefore, you could use an XS modifier in this situation. If both of them were close to each other on the right forearm, then you wouldn't use that XS. You would, just code for what it is you're performing. The MUEs, again, are the maximum units of service for a particular service, for that procedure code for that patient on that same day. Not all procedure codes have MUEs, and not all MUEs are publicly available. What you need to have, though, is documentation to support either why you are doing the two particular services or why you have more units of service than what the MUE actually calls for. So that's all going to be documentation. Especially with the MUEs, you will need to submit an appeal if you receive a denial. And then you'll need to tell us within that documentation exactly why Medicare should pay these additional services, why these additional services were appropriate. So the next thing that we have then for you are just some resources. We have the Medicare Benefit Policy Manual, the Medicare Claims Processing Manual, and you can see we've got a couple of different sections there. We provided you with the MLN on global surgery. We've got information for you there on the JZ modifier, which also includes information on the JW, information on National Correct Coding Initiative, and then that last MLN on that page are the proper use of those modifiers, the 59 and then the X modifiers. We also have a link for you on those LCDs and LCAs that we talked about. And then we have the WPS modifier fact sheets. And then we also have for you a link to our YouTube channel. Now, the next thing that we're going to do is take questions and answers. We did receive some pre-submitted questions that I'm going to go over first. One of the questions was, how do you code a procedure that's been performed using V-note, vaginal natural orifice transluminal endoscopic surgery? Well, this is just like any other procedure that you might be performing. Look at the code descriptions for the surgery that it is you want to accomplish. If that procedure code indicates different approaches, then you're going to use the one that best describes what you're doing. If the surgery that you're providing does not indicate any separate codes for separate approaches or different approaches, then you use the procedure code that best describes exactly what you have provided. Another pre-submitted question is how to bill for the post-delivery hospital E&M when another physician, not the same specialty, billed for the delivery. Well, there's some couple of questions that would go along with this one. If the provider who delivered the baby is transferring that patient's postpartum care to you, then you would need to bill using the same procedure code they did with a 55 modifier. And then the surgeon, the person who actually delivered the baby, would need to use that 54. If you're not if that surgeon, the doctor who did the delivery, is not transferring care, then you would simply bill your E&M services. There's no modifiers or anything else you need to apply. Another pre-submitted question is, what is the data service that you would bill when you're doing a delivery? Well, that's going to be the date that the baby was actually delivered. So all of your E&M services that are required by CPT, all of those, your postpartum services, they'll all be included on that one date under that delivery charge. And so then the question went on to say that our office has provided all of the antepartum care. We anticipated doing the delivery, and we are going to provide the postpartum care. However, the baby was actually delivered by the ED physician. What do we do now? Well, what you do at this point is you're going to bill that antepartum care and the postpartum care. So there are procedure codes in the CPT for postpartum care only. There may be a procedure code, it's just gone out of my head right now, for antepartum care only. If there isn't, you'll simply bill the E&M services that you provided. And then the next question that we had is, does CMS Medicare cover sterilizations? And the answer to that is really going to depend on the status of your procedure code and what you have going on with that. Medicare only covers for the treatment of an illness or injury. Medicare has a national coverage determination, which is NCD 230.3, and we're placing a link to that in the chat for you. If your procedure code is non-covered, as there's no illness or injury, then you would include that GY modifier. The sterilization services can be provided as a medically necessary service. If they're provided simply to prevent future pregnancies, then they're non-covered. That's when you use the GY. If you have provided a voluntary advanced beneficiary notice of non-coverage to the patient, you can also append that GX. That ABN is not required since sterilizations are generally going to be a non-covered service, but it's always a good idea to let your patient know. And if you do give that, append that GX modifier. We have information on our website on the use of the ABN modifiers, and we're going to place that information into the chat for you also. So Leanne, we do have some additional time. Do we have questions?
Yes, Ellen, we do have several. I will start with a question from Lynn asking, can you provide clarification on pregnancy complications that are separately reportable in the context of blood pressure management? For example, a patient comes into the office 2 weeks postpartum with uncontrolled blood pressure due to complications from preeclampsia, and the provider adjusts her blood pressure medications. Is this separately reportable as an E&M visit? And then similarly, what if the patient requires treatment in the postpartum period for uncontrolled blood pressure due to pre-existing chronic hypertension? Is that separately reportable?
Okay, so what you want to look at there is this the normal process from delivering a child? Now, patients can have complications. Blood pressure obviously is a fairly common one. However, what the CPT describes is a normal delivery. Patient's doing okay, pregnancy's going okay, delivery is fine, postpartum care is okay. So what in the situation you've just described, you have an unusual situation going on. And so therefore, yes, you can bill that E&M service separately.
Okay, next question is from Robin, asking how do you bill if they tried to start labor but were sent home without delivery?
Okay, that's a good question. Two things you would want to look at there. Um, if you're the physician who is going to bill for the delivery service, then you would not bill separately for attempting to start labor and the patient left. If you are not the patient's OB/GYN who is taking care of the pregnancy, such as maybe an ER physician or something along those lines, you want to look to see if there's a procedure code specifically for that. If not, you could have an E&M service, um, but it would have to be someone, in order to bill anything for this, it would have to be someone who is not part of that delivery or not anticipating being part of that delivery.
All right, thank you. Next question. Our next question is from Sally. When referring to members of the same group or specialty as it pertains to global surgery, global OB care, are services for a nurse midwife that are within the same group tax ID but working in the same, or excuse me, yeah, are within the same tax ID but working in the same specialty as the OB/GYN physicians still considered part of the same group specialty even if they are credentialed with Medicare as different specialties?
Medicare's instructions on that are pretty clear, and I realize CPT gives you a different instruction. But for your Medicare patients, a nurse midwife is her own specialty. The MD or the DO are their own specialty. When an MD or a DO enroll with Medicare, they can self-designate a specialty. A nurse midwife, it can't. She certifies that he or she is a nurse midwife. So in the context of the question, a nurse midwife is not the same specialty as the physician.
All right. Next question is from Lords. And the question is, can you give a scenario how we can bill for code 99238 or 99239?
Okay, the 99238 and 239 are your discharge management services. The 238 is for 30 minutes or less. The 239 is for more than 30 minutes. And so what this particular evaluation and management service does is it is the work in providing the discharge instructions to that patient. So as part of that, the person billing for that is going to have a visit with that patient. They're going to be developing and providing that patient with their post-discharge instructions. That's what the discharge management procedure codes are about. Now, we will be having, I think it's in September or at the end of August, we're going to be having a webinar on evaluation and management codes, inpatient and observation care, and the 99238 and 239 will be part of that if you want more information on that.
All right. The next question is Debbie, but it's related. So if you're covering another physician, Dr. X bills for prenatal and post, can Dr. Z bill 59409 and a discharge summary of 99238 or 99239?
Well, if you're covering for someone within your own specialty, then you'll simply bill the global delivery charge. If you're not covering well, let me take that back. If you are doing what they call a locum tenens or reciprocal billing, then that original provider will bill for that. So for an example, Dr. Smith is, following this woman's pregnancy, and Dr. Smith has vacation scheduled, and he goes on vacation, and the lady delivers. Dr. Smith is the one who's covering for Dr. Jones. Then Dr. Jones is still the one that's going to bill for that, and they'll bill for the entire charge. Next question.
Next question is also from Debbie. Do you need an attestation on the delivery note when billing with modifier GC?
Yes. The teaching physician guidelines, and we have information on our YouTube channel on teaching physicians, and that does talk about the attestation statement that needs to be present by that teaching physician and signed by that teaching physician in when they're billing for the fact that they were present while the resident was actually providing the service. And then the teaching physician would need to also sign that documentation.
Okay. Next question is from Cora. If the single-use vial contained 10 milligrams, but we only use 7 milligrams, we should use the JZ modifier. And then a follow-up question is, but what about the 3 milligrams that we're not using? Is that reported somehow?
Okay, and let me find that slide on that. Hang on a second, because I want to make sure I'm giving the right example. If your units of service are 10 milligrams, but you only give 7, you can only bill, the lowest you can bill to us is 1 unit of service. So you're going to bill that 1 unit of service with that JZ modifier. If you try and identify the 7 and the 3, it won't do anything for you, and it won't do anything for Medicare either. So you want to bill based on the units of service. So if 10 milligrams is your unit of service, that's what you'll bill to Medicare, even if you only gave 7. Now, in the example I gave on that particular slide, if your unit of service is 1 milligram and your single-use package is 10, then you have the split, the 7 that you administered and the 3 that you did not. Next question.
All right, and Ellen, we have 4 more that have come in. So
Okay.
the next question is from Margie. Should RHC clinics bill maternity services globally?
I have not found anything that tells me different than that. You would bill, as long as you can bill that surgical procedure code, then yes, it would be better for you to bill a global service. Next question.
All right, this one's from Carla. If a patient comes in during a postpartum period for blood pressure check and no medication, just check due to having developed preeclampsia during pregnancy, is this a separately reportable E&M outside of the postpartum global billing code?
No, if it's part of your postpartum care for that patient, then it is based on how you have described it. It is simply part of your delivery charge.
All right. Next question's from Miko. Do you need an attestation on a C-section?
If you have a teaching physician situation where the resident is providing that C-section as opposed to the teaching physician, then yes, you would need that attestation. And you would need to follow all of the teaching physician guidelines.
All right, and Ellen, this is the last question that we have in the chat. This is from Jenny. The question is, do IUDs require a JW modifier?
You want to look at the package insert on that. The two situations that we have heard described on the single-use package are the drugs, obviously, and then we have also heard it described based on like skin substitutes. So what you want to look at is the package insert from that manufacturer. Obviously, an IUD is only going to be used for one patient, but look and see whether or not they identify that as a single use package. If so, then you would need to use that JZ modifier, because again, obviously you're not going to apply only half of it. But look at the package insert. And so we are kind of close on time at this point then. So a couple of other things I want to let you know about. Where CMS and Noridian are hosting a provider enrollment conference in San Diego, August 28th and 29th. The conference itself is free, which is exciting in and of itself, and it will talk about everything that goes along with provider enrollment. You can see we have a link for you, and Leanne has placed that in the chat of the description and then how to register for that. CMS is also hosting a virtual provider compliance conference, and this is August 7th and 8th, and you can see the times there, 12 to 4 p.m. Eastern Time. And then this will be on all kinds of different topics dealing with compliance. The MACs across the nation will be speaking. WPS will have one of the presentations. There will be other people speaking on compliance. There will be a way that you can ask questions. So it's really kind of exciting. But again, the link is there for you for your agenda and registration. So on behalf of Leanne and I, we do want to thank you for attending today. We hope that we have provided you with great information on the more common services billed by OBGYNs. We do encourage you to take that survey. Again, it only takes a few minutes. We are very interested in your feedback. We want to be providing you with excellent customer service. So thank you so very much. Hope you have an absolute wonderful day, and you can now disconnect.